Good evening, everyone. Can somebody confirm if I'm audible and visible, just to make sure that there is no technical problems? As soon as you confirm, I shall just start the session today. Please let me know in the chat box. Aryan, Venkata, Vijaya Kumar, all of you. Okay, thank you. So welcome to this Pocket Clinics series by PW Meded. I'm your dermatology faculty, Dr. Jazeer. And today we'll be talking about a specific condition called as a ringworm, which is the Tinea corporis, and few other types of dermatophytosis. The basic idea of today's session is that if when you're going to head towards the OPD tomorrow, and when you're going to see the patients, so how should be your approach? What all things you have to keep in mind when you see some skin diseases is what we are going to discuss in this session. And we'll be focusing on fungal infections, but let us see how the thought process works as a clinician. Okay, so with your permission, I'm gonna start with the first slide. Now you can see that every rash is not eczema, and every annular lesion is not tinea. And learn to think like a dermatologist, because once you go to a skin OPD, I'm sure that you must be seeing a lot of cases, and every time you see a case, it's very important that how do you recognize these patterns, right? So if you don't have any idea, if you just see some random cases and all, probably you may tell it to yourself, there is a patient who is having a annular kind of a lesion, a round lesion, isn't it? But not every round lesion is going to be a ringworm infection, right? It can be sometimes tinea, it can be sometimes psoriasis, it can be sometimes eczema or any other disease. So what the idea today is, we will try to do some cases, just see those cases and just try to interact today to tell me what are the differential diagnosis of these cases, and we'll try to see how our approach should be when you are going to approach these diseases. To begin with, let's begin with the first case. And the first case is, okay, walaikum assalam. And so this case is going to be a 26-year-old. Just a minute. A minute. Yeah, a 26-year-old male presents with itching over the trunk for the last 3 weeks, rash that is gradually increasing in size, similar lesions appearing nearby, and no fever or any other systemic symptoms. So, what is your provisional diagnosis here? So, when you see that any patient is coming to you, and you can see that the patient is saying, for the last 3 weeks, I'm having this kind of a lesion in my trunk, and it is constantly increasing in its size. And the patient is also complaining that there is some itching as well. So, यहाँ पे जो itching है, a very important clue for you. And this itching, which is increasing in its size as well. So anyone in the chat box, can you tell me what is a provisional diagnosis that you have in this case? What is a provisional diagnosis? What should you think when the patient is coming to you with these kind of symptoms? Any idea? So before we go into a provisional diagnosis, it can be, let's say that provisional diagnosis probably a fungal infection, isn't it? A fungal infection. But let us try to analyze now. Now we kya karenge? We'll just try to examine the patient. Abhi when I examine the patient, I can see that where is the scaling present. First of all, yeah, Anand is saying that it should be tinea. Yes, Anand, I agree. But let us see, how did you reach to a diagnosis of tinea here? First of all, let us talk about the shape of this lesion. The shape is something like this. So what is the shape? It's going to be an annular shape, that is round in shape. So on examination, you can see that the lesions are annular in shape. Along with this annular shape, the borders also, they're well defined, right? So they have a well defined borders. They have a well defined borders. और तीसरा जो है, it is about the scaling that we will talk about. So in this image, where do you see the scaling? Do you see that the scales are present throughout the lesion, or the scaling is present towards the periphery of the lesion? यहाँ पे you can see that the scaling is present towards the periphery of the lesions, right? So here you can see peripheral scaling. Peripheral scaling. So because the scales are present towards the periphery of the lesion, that is why in the central part, you can see this is what we usually call it as a central clearing as well. So this is called central clearing. So see such a small image, एक छोटा सा round annular shaped lesion, but we are able to say that these are all the findings. जैसे round in shape, annular in shape, well defined borders है, peripheral scaling भी है, right, and central clearing भी है. Yeah, for the final years also you can understand, because these are all case based scenarios that we are discussing, so it will be good to understand the approach here. Okay. Now, what conditions can present like this? अब ये बताओ, when I ask you कि tomorrow for the rounds or during the OPD, if the professor is asking you what all differential diagnosis do you have when you see such a lesion, can anybody in the chat box let me know what could all these things could be? What could be the differential diagnosis for this condition? And the simple thing is, it's a itchy lesion when it is something like this in shape. So what are the differential diagnoses that you would like to add? पहले जो differential diagnosis होगा, somebody was telling me about tinea या Aryan. So this should be a tinea corporis. Tinea corporis, which we usually say ringworm, है ना? तो ये हो गया ringworm. Other than ringworm, is there any differential diagnosis that comes to your mind? बस एक बार और just try to give a guess. It's okay even if you are wrong. जैसे round lesions in the skin, क्या हो सकता है? Round lesions क्या हो सकता है? So do you think that any kind of eczema can present to you with round lesions? The eczema which presents to you with round lesions is called as a nummular eczema. It's called as a nummular eczema. Agar patient diabetic hai, then these kind of diabetic patients, they also can present with a round lesion. Do you have any idea what is it? वो होता है granuloma inguinale. Isn't it? Sorry, granuloma annular. So it is going to be granuloma annular. Annular. That can be another differential diagnosis. Yeah, very good. Who is that? Sadhana is saying discoid eczema. Discoid eczema is the same as nummular eczema. And in some kind of psoriasis, right? Psoriasis में भी ऐसा हो सकता है, जैसे plaque psoriasis. Plaque psoriasis. When I say plaque psoriasis, जैसे small lesions जो होते हैं, round lesions like in gutted psoriasis, वैसे ही lesions होगा Pityriasis rosea में, isn't it? Pityriasis rosea. Pityriasis rosea. And what one more thing that comes to your mind, जैसे annular lesions, some kind of lupus erythematosus, and that is called as the subcutaneous lupus erythematosus. So all these are some of the differential diagnosis that comes to my mind when I say about a round lesion in the skin, right? So you'll have to force yourself to think more कि क्या क्या हो सकता है, because differentials है ना, so it can be anything that is round in shape, right? Now coming out to the main thing is that how do you rule out, जैसे ये टीनिया कॉर्पोरिस है या फिर नमुलर एक्जिमा है, ग्रैनुलोमा एनुलर एंड ऑल. So how do we rule out? Let us see one by one. So in case we are going to discuss about a nummular eczema, अगर ये जो lesion है, this lesion that you can see, if this was an eczema, will you see the scaling is in the periphery? नहीं ना. So you will not see that. History, please tell one. See, history बस इतना ही है कि 26-year-old patient है and his patient is having a itchy lesion for the last 3 weeks. ठीक है? And now similar lesions are appearing in other parts of the body and there is no fever and no systemic symptoms. ठीक है? Yeah. So this is going to be the differential diagnosis. अब देखते हैं कि nummular eczema में why is it less likely? क्योंकि nummular eczema यहाँ पे जो स्केलिंग होगा that will be a diffuse scaling, right, which is, and you definitely will not see central clearing. No central clearing can be seen in a discoid eczema or a nummular eczema. जो entire lesion होगा, over the entire lesion you will be able to see a diffuse scaling. The next one जो psoriasis है, so I'll just show you the image also. See, this is the image of a nummular eczema. So this is called as a nummular eczema. Why do we call this as a nummular eczema? क्योंकि because of the coin shaped eczema, जो round shape होता है, this is called as a coin shaped eczema or a nummular eczema. यहाँ पे कोई peripheral scaling वगैरह नहीं है, right? Whereas when you see some lesion like this, जहाँ पे erythematous plaques है, red color plaques, and there is an entire silvery white scaling, So this could be a example of a plaque psoriasis, right? So plaque psoriasis mein what do you see? Plaque psoriasis mein you can see that the patient may be having silvery white scaling. Silvery white scaling can be seen, and that too mostly over the extensor surfaces. Mostly over extensor surfaces. Yeah, another clue hoga for psoriasis. And then coming to the next one, let us see the image also. So this is what you call as granuloma annular. Okay, this is called as granuloma annular. And this is very common in diabetes patients. In DM patients, it is going to be very common. Abhi, this granuloma annular, it is very typical. Because I've already zoomed this image for you. Can you see that there is a normal skin in the center, right? And then you can see that there is a lesion with a raised edge, right? So this is how it presents, that is granuloma annular. और usually क्या होगा, यहाँ पे कोई scaling नहीं होगा, there is no scaling, and it is going to be a raised lesion towards the periphery. Okay, so the difference is when you observe these kind of lesions in granuloma annular, you can see a central normal skin, no scaling, and this is going to be a asymptomatic lesion. Asymptomatic lesion. So in our question, our patient was like, there is a itching. So यहाँ पे कोई symptom नहीं होगा, and this is called as granuloma annular. So these are, see, there are some skin conditions. Smarayana Hati, right? So there are few skin conditions that is typically seen in some disease. जैसे diabetes में you can see granuloma annulare, necrobiosis lipoidica diabeticorum. So there are some conditions it is very specific to diabetes. Some conditions typically seen in thyroid diseases, जैसे pretibial myxedema, right? So once you see those cases, you'll understand. So here it is more commonly seen in DM patients. और नेक्स्ट वन जो है पिटीरियासिस रोजिया. सो हैव यू लर्न पिटीरियासिस रोजिया व्हाइल यू डिड योर सब्जेक्ट? जैसे इन पिटीरियासिस रोजिया में क्या होगा, द पेशेंट विल फर्स्ट डेवलप द बिगेस्ट लीशन. ये जो बिगेस्ट लीशन जो है, दैट बिग लीशन इज हैविंग अ नेम. द बिगेस्ट लीशन विच इज यूजुअली द फर्स्ट लीशन, दिस इज कॉल्ड एज द हेराल्ड पैच or the mother patch or the mother patch. So whenever you see a very big lesion which is surrounded by multiple smaller lesions, this could be a case of pityriasis. Pityriasis rosea. It's going to be a case of pityriasis rosea. This is what you should understand when you see multiple lesions like this. So here in pityriasis rosea, you can see a herald patch or a mother patch can be seen, and multiple lesions can be seen, and multiple lesions can be seen. Done. The next one is subcutaneous lupus erythematosus. Now why subcutaneous lupus? जैसे lupus erythematosus SLE, everybody will know कि malar rash हो सकता है, right? Photosensitivity हो सकता है, aphthous ulcers हो सकता है. All these things are going to be the common symptoms in SLE. But there is an entity which is called as subacute, isn't it? That is called, this is going to be SCLE. It is going to be cutaneous lupus erythematosus. Subacute cutaneous lupus erythematosus. यहाँ पे क्या होगा? This is the type of SLE where you can see annular lesions in the skin. So this is the lesion. This is the area where you can see annular lesions, and these patients may have ANA positivity. उनको photosensitivity भी होगा. All those things will be present. But after every time they go out to the sun, and when they come back, they develop these kind of annular lesions. इसीलिए यहाँ पे this is going to be one of the differential diagnosis. So in the same table, we will mention that these patients will have photosensitivity. So these patients will have photosensitivity, and you will also get some systemic clues. And you will get also some systemic clues. So this is what you can see in a patient of SCLE, that is cutaneous lupus erythematosus. And the last one, Tinea corporis. Tinea corporis will just add here, but we will not mention because why it is less likely बोल रहा हूँ मैं अभी. But यहाँ पे most likely lesion जो है, it is going to be Tinea corporis, right? So why do I say that I am suspecting Tinea corporis in this patient? First thing is the scaly border. यहाँ पे क्या होगा कि इमेजिन करो कि दिस इज अ पेशेंट हु केम टू अस, बट व्हेन यू आर गोइंग टू सी दिस पेशेंट, इनिशियली इट मे हैव स्टार्टेड विद अ एनुलर लीशन लाइक दिस. If you don't treat the patient for one more week, क्या होगा? The lesion will expand like this. After some time, the lesion may expand like this. So this is what you can say, a actively scaly expanding border is going to give you the best diagnostic clue that this could be a Tinea corporis. This is why we call this after. Uh, this is why we call this as uh, Tinea or a ringworm or a ringworm. Or a ringworm. Clear? Why after sun exposure this happened? क्योंकि मैं पहले बोल रहा था about subcutaneous lupus erythematosus, isn't it? So when there is a cutaneous lupus erythematosus, every type of lupus is going to be photosensitive. It is going to be photosensitive, not just SLE, but SCLE is also going to be photosensitive. Clear? So now this is what I'm thinking about. Now, can you quickly tell me when you're going to see all these kind of lesions tomorrow, but at the end of the day, if you're suspecting a fungal infection, आपको कौन सा investigation करना चाहिए? One investigation and you rule out everything. You do just one investigation, that is a clue for you. Do one investigation और आप easily Annular eczema, psoriasis, Granuloma, Annular, Pityriasis, Rosea, SCLE सब कुछ rule out कर सकते हो. Can anybody let me know in the chat box ki what should be our investigation of choice? I'll just wait for a few seconds for you to answer in the chat box and then I shall continue with my session. Very good. I have already got the right answer in the chat box. So somebody is telling that it is going to be a KOH mount. How many of you agree? ये क्या है ये KOH mount? This is going to be a potassium hydroxide test, है ना? So this is the investigation of choice whenever you suspect a fungal infection. तो यहाँ पे वुड स्लैम एग्जामिनेशन ठीक है, वुड स्लैम भी कर सकते हैं, बट देन वुड स्लैम in a tinea infection, wood slam is not going to give you any kind of a fluorescence except when it is going to be tinea capitis. Tinea capitis में you may get a fluorescence, but ये जो skin lesions होते हैं वहाँ पे you may not find. ठीक है. So now let me just see what additional history you will be taking. जैसे patient has come to you with a itchy lesion, right? You always should ask, does anybody have a similar lesion in the family? Because this is a contagious disease. It can spread from one person to the other. So you can ask that whether anybody else is going to have this kind of a disease. And you can see if there is any pet exposure. Because some kinds of tinea capitis and tinea infections may be transmitted from a domestic pet, just a cat or a dog, right? Excessive sweating. So whenever you sweat a lot, you are automatically exposed to a fungal infection, right? So do you sweat a lot should be one of the questions that you will be asking. And gym usage. Why? Because so many people will be using these instruments in the gym and they all would be sweating as well. So the gym and all may be a good place where these kind of fungal infections could be transmitted. And then did they do any previous treatment, whether they are diabetic or not? Because diabetes again makes you more prone to infections, and if they are using some suppressive drugs and all, right? तो अगर कोई steroid tablets ले रहा है like for some amount of time, so then what happens? Because of suppressing the immunity, they may be prone to infections, especially fungal infection. That is going to be one very important finding here. Now, as you have told me earlier, somebody had told in the chat box that this is going to be the investigation of choice. So you just do a simple KOH test. Okay, once you do a KOH test, that is going to be the best method how you can diagnose this condition called as Tinea corporis or dermatophytosis. Okay, that is how you should do. And why you should rely on a KOH test. जैसे how many of you have seen how a KOH test is done? Afsana, you're right. That is going to be a KOH test. Because why? It's very easy test because near the OPD, you can do it very fast. So it is going to be very rapid. Less cost is involved. And quick diagnosis हो सकता है. Quick diagnosis. Because just try to understand कि KOH, how is it done? So if you want to understand how a KOH mount is done, if you're suspecting a fungal infection anywhere, just send them to the lab, right? In the lab, what they do is they'll take a blade and they're going to scrape over this lesion. So once they scrape over this lesion, whatever the powdery kind of a material that comes out, you're going to collect it under a glass slide. And once you collect it under a glass slide, just put 2 drops of potassium hydroxide, that is 10% or 20% of a potassium hydroxide, and then you examine under a microscope. Under the microscope, if you can see something like this, so what you see here now, yeah, so this is how you can do a KOH. Okay, and this is the finding in a KOH. Like exact KOH image ऐसा ही होगा, and here you can see the fungal elements. क्योंकि ये जो potassium hydroxide है, what does it do? It is going to dissolve the entire skin cells. सारे जो skin cells हैं, it gets dissolved. Now अभी बाकी क्या रहेगा? It is going to be the fungus. If the fungus is present, you can only see the fungus. और यहाँ पे एक branching septate hyphae. So the finding here is a branching septate hyphae is what you can see. Is what you can see. I'll just zoom this image. So all these long strands that you can see, isn't it? So these kind of long strands, they are actually the fungus. So these are the long strands, which is going to be the fungus. The moment you see, hyphae दिख रहा है, मतलब fungal infection is going to be confirmed. Fungal infection तो confirm हो गया. पर यहाँ पे just understand one thing. Like how do we do a gram staining and all based on the properties and all, you may be able to say which bacteria, or even in any bacterial infection, if you do a culture, a bacterial culture may be available with the results within a 2 or 3 days, right? But that is not how it happens in a fungal infection. And it's a very important point that you can be questioned anytime about it. So always remember, if you are going to suspect a fungal infection, बस एक KOH mount करो. Once you see a fungal hyphae or a pseudo hyphae, आपका diagnosis confirm हो गया कि ये fungal infection है, you start the patient on antifungals. But it does not identify कि which species is there. So it is not going to identify which is the species that is causing the fungus. Now, do we need a fungal culture in every patient? क्या लगता है? Can anybody answer? हाँ, वो जो thread like structure है, that is going to be the hyphae. और यहाँ पे can anybody answer that do we really need to do a fungal culture? क्योंकि in bacterial infections and all, we always do a bacterial culture. But how about fungus? Can anybody answer? What is your thought process? क्या फंगल कल्चर करना ज़रूरी है फॉर ऑल दोज सस्पेक्टेड फंगल इन्फेक्शंस, या KOH ही काफ़ी है? Just based on the KOH, are you as a doctor going to start the treatment on this patient? Quickly. So just let me know. No, it takes more time. Excellent. Anand Hospital, Maranya Hati. So all of them are saying ki no. Afsana, they all are saying that no, it should not be done. Yes. So what we do is that the answer here should be no. It takes at least 4 to 6 weeks to get a fungal culture results. तब तक patient must be fully cured, right? So patient must be fully cured. That is why the approach that we follow in the clinic should be, whenever you have a patient who is having a clinical suspicion of a fungal infection, then you just do a KOH which will be positive, and then you initiate the treatment. बस इतना ही करना है. Okay, clinical suspicion, KOH करो, treatment start करो. Don't wait for any fungal culture. And when do we do a fungal culture? Fungal culture तो 100% करते हैं. But when do we do? Like these are the circumstances when we do. अगर किसी का recurrent diseases हो रहा है, okay, extensive disease, मतलब there's a large body surface area which is going to be involved. आपने कोई anti-fungal agent start किया, but the patient is not responding to treatment. अगर treatment में कुछ failure है, right? And if the patient's disease has been already manipulated by steroids, so whenever we use steroids for the management of fungal infection, तो बोलते हैं Tinea Incognito. Okay, पर अगर what if your lab person is not competent enough? जैसे आपने बोला, जैसे आपने, you are going to send a patient to the lab. What if they are not able to properly do a KOH? है ना, उनका गलती से भी हो सकता है. So but KOH, they will just report कि KOH negative है, कोई fungal hyphae या pseudo hyphae is not seen. But still clinically you suspect कि हाँ, but then I still feel कि ये फंगल इन्फेक्शन हो सकता है. सो ऑल दोज थिंग्स, इवन इफ यू वांट टू आइडेंटिफाई कि कौन से स्पीशीज हैज caused this infection, at those time also you can do a fungal culture. So these are the instances where you will be doing a fungal culture. So finally coming towards the फाइनल डायग्नोसिस हियर. अभी फाइनल डायग्नोसिस क्या है, क्योंकि डर्मेटोफाइटोसिस इज अ बिग स्टोरी कि देयर कैन बी एन इन्फेक्शन ऑफ द स्कैल्प, इसको बोलते हैं टीनिया कैपिटस. फेस टीनिया फेशाई. ओवर द बियर्ड एरिया टीनिया बार्बे. राइट. सो यहाँ पे क्या होगा, जस्ट मेंशन किया है कि पेशेंट इज हैविंग अ राउंड कलर itchy lesions over the trunk. So the final diagnosis of us should be a tinea corporis. तो टीनिया कॉर्पोरिस में जो यूजुअल जो ऑर्गेनिजम्स हैं, इट कैन बी अ ट्राइकोफाइटोन रूब्रम. ये जो रूब्रम है, दिस इज गोइंग टू बी द मोस्ट कॉमन, or it can be also caused by trichophyton mentagrophytes. Okay, all these things are the common causative organisms which can cause a tinea corporis. And coming towards the treatment part, हम सीधा ट्रीटमेंट में जाएंगे. लाइक इफ देयर इज अ वेरी स्मॉल बॉडी सरफेस एरिया, मतलब अगर पेशेंट को एक 5 सेंटीमीटर डायमीटर में एक राउंड एनुलर लीशंस है, उस टाइम पे इट इज़ नॉट नेसेसरी दैट यू गो फॉर एनी oral antifungal agents. You can go for a terbinafine cream which can be showing a very good response, or anything like a clotrimazole, ketoconazole, all those things. But yes, keep one thing in mind. Yeah, it is over the hair bearing area, that is called as corporis. Okay, but keep one very very important thing in mind. Because when you are going to do your practice, when you see a fungal infections, आप prescribe करोगे terbinafine, right? So once you prescribe terbinafine, after a couple of weeks, let's say after 3 weeks or 4 weeks, patient is getting a wonderful improvement of symptoms. But when will you stop the medication? Yeah, but it's a very very important thing that you should remember, that see, a fungal infection may take 4 to 6 weeks for complete cure. Matlab 4 weeks is equal to almost a month. 6 weeks matlab almost 40-45 days. Now, do not stop the treatment. Continue the treatment for 2 more weeks after complete clearance of the lesion. Okay, the entire skin has become normal. फिर भी आपको एडवाइस करना पड़ेगा कि do not stop the treatment now. Continue applying it for 2 more weeks. Otherwise, what will happen? You have seen that the lesions have improved. आपने ये जो antifungal creams या tablets जो है वो discontinue किया, and then the patient may have a flare up again. So the patient may have a flare up again. That is called as the treatment. So please remember that you should go for a treatment for continue the treatment for more than 2 weeks, even after complete clearance of symptoms. Okay. And what if the body surface area is more, जैसे more than 10% of body surface area is involved? So if more than 10% of body surface area is going to be involved, then what you need to do is go for any tablets, and our drug of choice will be a terbinafine. You can go for a terbinafine tablets, or you can go for itraconazole tablets, fluconazole, griseofulvin. All those things are going to be excellent and responsive to tinea capitis. Clear? So sorry, tinea, all types of tinea. Let's say all types of tinea. So let us see one more case now. So the second case is the next patient is coming to you. The patient is a 35-year-old patient, obese patient hai, and his complaint is that there is a severe itching in the groin area, and the symptoms is worsening after sweating, and this is present for the last 2 months. So now I guess you have a better idea कि approach कैसा होना चाहिए. Patient is having sweating, itchy lesion, or groin area में है. So probably this lesion was somewhere like this. After 1 or 2 weeks, it is like this, which means the lesion is expanding now. So what should be your differential diagnosis? अगर कोई patient आ रहा है with a complaint of this kind of a lesion over the groin area. अभी यहाँ पे what is your finding? पहले अपना examination findings बताओ. So in this image, what do you see? You can see that. What is the color? You can see that there's some erythematous plaque lesion, right? So यहाँ पे जो lesions है, it is going to be a erythematous plaque. और जस्ट लाइक एनी अदर टीनिया यहाँ पे भी पेरिफेरल स्केलिंग होगा. Peripheral scaling is present, and the lesion is present in the groin area. The lesion is present at the groin area. And what else? So all these are going to be the findings. अभी यहाँ पे what is your likely diagnosis? What is the likely diagnosis here? Anybody? Yeah, Anand Hospital is saying Tinea Cruris. So let me put a provisional diagnosis as Tinea Cruris. Excellent. It's a very good provisional diagnosis. So first, before we talk about this provisional diagnosis of a Tinea Cruris, let us see as a good physician, what should be your differential diagnosis for a groin rash. Groin region में अगर एक patient is having some kind of a lesion, what are the differential diagnosis? One differential diagnosis जैसे आपने बताया Tinea Cruris है, Tinea Cruris. What could be other things? Have you like experienced like in peak summers and all, or when you walk a lot because of the friction, right? You may develop some maceration, some erosions in the skin, and there may be a super added fungal infection also. So that is called as, that is not tinea usually. So that is going to be candidal intertrigo. Candidal intertrigo. जैसे intertriginous region में जो fungal infections होता है, so this is not usually dermatophytosis, वो candidal intertrigo हो सकता है. Anything else? जैसे groin area में, if the patient is having a dark color skin, that is also can be a differential diagnosis, right? So what is that differential diagnosis? Yeah, this differential diagnosis is called as erythrasma. I'll show you all the images so that you'll be able to correlate it better. Okay, erythrasma ho sakta hai. Very good. Yeah, Apsana is saying it. Nice, very good. And any other systemic disease or something that comes under general dermatology? Is there any type of psoriasis जहाँ पे patient को जो lesions है that is seen in the groin area, axilla, सारे जो flexures में दिखते हैं? Yeah, this is called as inverse psoriasis. Inverse psoriasis. Inverse psoriasis has one more name. It's called as flexural psoriasis. Flexural psoriasis. So inverse psoriasis, flexural psoriasis. Sadhana is telling another very good differential diagnosis. ये diaper rash हो सकता है. Diaper rash. But let us reserve the diaper rash in infants or in bedridden patients. Okay, if they are using a diaper. Right, very, very good. Yeah, very good. One more excellent differential diagnosis by Afsana. It's Haley disease. Very good. It's a very good thought process. Haley disease. So it is called as benign pemphigus, familial pemphigus, right? जहाँ पे vesicular bullous lesion होगा over the intertriginous sites, including the groin area. So very good. So all these are different types of differential diagnosis. Now again हमारा approach क्या होना चाहिए? क्योंकि हम सबसे आगे we are expecting a tinea. So the first investigation we should do should definitely be a KOH. But then still, let us see how do we differentiate all these conditions based on what we can see. जैसे अगर ये tinea cruris है, it will be having a actively scaly border, right? Active scaly borders होगा. Because in any of the tinea, scaly borders होगा and it will be constantly expanding. ये हो गया आपका सबसे important clue, right? That's going to be the most important clue. अगर candidal lesions हैं, जैसे candidal intertrigo, यहाँ पे क्या होगा, जो erosions और maceration मतलब it is mostly a skin that is because of the sweat and all, when it is soaked in water or it is there is going to be set and the skin, the consistency will change. It's called as a maceration. And sometimes you can see some satellite pustules also when it comes to candidal intertrigo. अगर ये एक एरिथ्रास्मा है, यहाँ पे सिर्फ एक हाइपर पिगमेंटेशन होगा. And if you want to rule out erythrasma, is there any investigation that you would like to do? जैसे you are doubting कि ये erythrasma है, which is a bacterial infection, या एक fungal infection हो सकता है. Fungal infection के लिए you can do a KOH test. एट द सेम टाइम एक सिंपल ओपीडी प्रोसीजर है या फिर ओपीडी इंस्ट्रूमेंट है which you can just turn it on over the erythrasma site to see if it is going to be erythrasma or not. Can anybody tell me what is it? Yeah, this could be a Woods lamp examination. यहाँ पे you can see a coral red fluorescence. So Woods lamp examination where you can see a red color fluorescence. Red color fluorescence आ गया, then you know that it is going to be erythrasma. I'll show you some of the images also. ये जो image है, this is what I mentioned, some erosions and all can be seen. अगर clinical picture ऐसा है, then this is most likely to be a candidal intertrigo. This is most likely to be a candidal intertrigo because of the frequent rubbing. Okay, this is because of the frequent rubbing of the thighs, between the thighs. फ्रिक्शन के वजह से जो होगा, इट इज मोस्ट लाइकली टू बी अ कैंडिडल इंटरट्राइगो. दूसरा जो है, दिस वन इज गोइंग टू बी हाइपर पिगमेंटेशन है ना, दिस कुड बी एरिथ्रास्मा बिकॉज यू नीड टू डिस्क्राइब द लीशंस. अभी इसको कैसे डिस्क्राइब करोगे? दैट देयर इज अ ब्राउन कलर हाइपर पिगमेंटेड पैच लीशन and this erythrasma is usually a non-itchy condition as well, whereas candidiasis भी itching होगा और टीनिया क्रूरिस में भी itching is present. अब ये तीसरा इमेज देखो, इस इमेज में क्या है? वी कैन सी दैट द स्किन हैज बिकम रेड इन कलर है ना. यहाँ पे एक एरिथेमेटस प्लेक, शाइनी प्लेक लीशन दिख रहा है आपको. सो व्हेन यू सी रेड शाइनी प्लेक लीशंस, then think about inverse psoriasis. Inverse psoriasis. Candida more common in summer. Obviously, yes. The more you sweat, the more likely that you may get a candidal intertrigo. And whoever was answering about coral red fluorescence like Afsana and all of you, very good. So all these could be the thing. So in inverse psoriasis, what you see? In inverse psoriasis, you can see that there are smooth, shiny plaques. Shiny red color plaque lesions hoga. So all these are going to be our differential diagnosis, and you score your marks in differential diagnosis, right? So the more you can think about differential diagnosis rather than just fixing on one disease when you see. So that is how your clinical thinking should develop. So that's about this thing. So the most important thing. Okay. And this is your takeaway for today, right? So the takeaway is that one just minimize my chat, just a minute. Yeah. So always remember that when you get a patient who is having a Tinea cruris, so यहाँ पे our diagnosis was a Tinea cruris, right? So whenever you see a infection in the groin area, always examine the foot of the patient. क्योंकि Tinea pedis often serves as a fungal reservoir. You have to check for the foot of the patient. If you see some suspected rashes in the foot, then you better apply antifungal agents in the foot as well, because from the foot the patient may develop a Tinea cruris. क्योंकि reservoir may be in the foot and the patient will be having symptoms in the groin area. So it is better you correct it entire thing, right? So here, what is the key management of Tinea cruris? So just keep the area clean. Let if there's a patient who sweats a lot, ask him or her to repeatedly wash the area, and always wear some loose cotton clothings rather than going for tight innerwears and all. And weight reduction, it's very common in obese patients that they develop this kind of fungal infection, so weight reduction should be done. And also always check if the patient is having some associated Tinea pedis as well. Clear? That is going to be our treatment approach when it comes to the treatment of Tinea cruris. Or treatment will be the same, जैसे we have discussed about Tinea corporis earlier. So based on the body surface area आप decide कर सकते हैं, जैसे topical agents apply करना चाहिए या फिर oral agents. And do not stop the treatment until and unless it is going to be 4 to 6 weeks. And once the entire lesions will disappear, please continue the antifungals for 2 more weeks. That's the most important part. It applies commonly to all the fungal infections. ठीक है. अब देखते हैं one more case today. और तीसरा जो केस है that is this one. Okay, so a 28-year-old female presents with a itchy rash over the trunk, diagnosed elsewhere as eczema, and is using a cream for last 2 months. You have no idea what is a cream, and now the lesion is becoming larger. This is how you can see the patient is presenting to you. Anybody right now, you can see that a patient is having a round hyperpigmented lesion like this. Some non-specific kind of a lesion. I don't see any scaling. कोई scaling नहीं है, एक hyperpigmented lesion है. But the patient is saying that वो initially वो जो lesions था, it was red in color. अभी मैंने कुछ creams apply किया. Cream apply करने के बाद what is happening? The lesion is still becoming larger. So what could be the diagnosis here? Yeah, the diagnosis here could be, when you ask this question, which cream did you use before, or have you used any cream? And here the patient is bound to give you a reply saying that yes, I have used some steroid creams, but the steroid creams never worked for me. Okay, the steroid cream never worked for me. Like there are so many steroid creams, like it can be a betamethasone. Patient usually will come to the OPD taking all those previous medications and all. So these small ointments or creams that they keep on your consulting table, it can be either a betamethasone, or it can be a clobetasol, or it can be a mometasone. All those creams, like, so this is going to be the reason for a patient to develop a tinea incognito, क्योंकि topical steroid misuse is the most common cause. तो यहाँ पे क्या हो रहा है? There is a topical steroid misuse that is happening, जिनके वजह से the patient is developing this kind of a lesion. And what do you mean by tinea incognito? Usually what is your expectation? जैसे अभी we have learned, right? अगर एक tinea corporis है, you are expecting a annular lesion, right? And just on the extremities of the lesion, you are expecting the scaling. Now imagine that you're going to apply a steroid cream. This steroid creams, so this is actually steroid modified tinea. It is going to be steroid modified tinea, because यहाँ पे क्या होगा? A steroid cream, can it kill a fungus? The answer is no. So this is not fungicidal. It cannot kill a fungus. But a steroid cream is having a anti-inflammatory property. Anti-inflammatory property. So since they have anti-inflammatory property, that is the reason why scaling will disappear. Itching will also reduce. All will disappear. But the lesion is still present because the fungus is still there. It's called as tinea incognito. It's called as tinea incognito. Clear? So here, what are the diagnostic clues? Like when should you suspect a tinea incognito in any patient? Yeah, very good. Smooth specialist. It is going to be steroid modified tinea. And when should you suspect a tinea incognito? You can always suspect that when the patient says that the eczema, when the patient says that I was diagnosed of eczema, right? And this is worsening with steroids. अगर कोई भी eczema worsen हो रहा है because after applying steroids, that is a rare possibility. It never happens. आपने misdiagnose किया होगा, right? So this is not because of eczema. It should be because of a fungal infection. So we name this as a tinea incognito. Okay? Or otherwise, while taking treatment, the lesion was becoming smaller or some changes was happening. अपने steroid stop करने के बाद, this lesion is enlarging. So lesion is enlarging after treatment. So in all these type of clinical scenarios, think about tinea cognito in your mind. And what is the investigation that you will do? See, how do you identify an eczema is a good question, because eczema जो skin allergy है, जब acute eczema होता है, acute eczema always has a oozing kind of lesions. Oozing मतलब patient को कुछ papules होगा, vesicles होगा. Vesicles are definitely seen in an acute eczema. acute allergic phase will have a oozing out lesions. फिर क्या होगा? In the chronic phase वो थोड़ा stabilize होंगे, फिर कोई vesicles नहीं होगा, it will be kind of a plaque lesions which you can see. So you need to take a history and you need to see what are the symptoms also. Is that clear? Yeah. And what is the investigation? यहाँ पे फिर से you are going to do a KOH test, क्योंकि KO यहाँ पे KOH तो 100% पॉजिटिव ही आने वाला है. Even though the lesion does not look like a fungal infection anymore, still it is going to be positive क्योंकि steroids are not fungicidal. Steroids are not fungicidal. Clear? And then what should be our treatment? Treatment is simple. You need to stop something and you need to start something. Tell me, what are you going to stop? आपने क्या गलती किया था इधर? Yeah, to treat this patient's skin lesion with a steroid. तो इसीलिए आपको steroids stop करना चाहिए. Or what are you going to start? You're going to start on antifungal treatment, like a terbinafine, itraconazole tablet, ketoconazole, whatever. So any antifungal agents should be started. So that is how you're going to continue with the treatment, and then what happens? The entire lesions will disappear. So that is all about these three clinical scenarios that we have discussed today. So some of the key takeaway messages today is, when you see a annular itchy plaque with an active border, active scaly border, always think about a tinea infection. Okay, so it's very important that you have a good observation. That is why we have hand lens and all kept in the dermatology OPD. So when you see a lesion, just try to examine it. See what is the entire morphology of the lesion, where is the scaling present. All these are going to give you a diagnostic clue, right? And scaling at the border काफी important है, because it is an expanding lesion, right? So इसीलिए scaling at the border should be a very very important clue for you to think about a fungal infection, right? And please don't settle with one diagnosis. आपने देख लिया एक round lesion, बता दिया कि हाँ ये ringworm हो सकता है. Don't stop yourself there. Always have a bunch of differential diagnosis. That is the only way how you will start thinking logically. आपको लॉजिकली सोचना पड़ेगा एंड इसके हिसाब से डिस्क्राइब करना पड़ेगा कि व्हाट आर द कैरेक्टरिस्टिक्स ऑफ द लीशन, एंड देन ट्राई टू रीच आउट टू द डायग्नोसिस. दैट्स द बेस्ट अप्रोच दैट यू कैन डू. एंड यस, अ वेरी सिंपल, लो कॉस्ट, easily available investigation is going to be a potassium hydroxide test. We should do potassium hydroxide test because that is also very important. And fungal culture, again, don't send unnecessarily fungal culture in case of skin infections until and unless you think that's a resistant case, treatment failure हो रहा है या फिर patient is not responding. Otherwise, don't go for a fungal culture. Just rely on a simple thing called as a KOH. Okay? And whenever you see a patient who is having a groin infection, Tinea Cruris, then don't just examine the groin area. You have to examine the foot of the patient, right? Because Tinea pedis could be the reservoir. So always examine the feet in a patient of a Tinea Cruris and ask about previous drug usage. And most of the times, especially today, it has become like an epidemic. The patient is like, कोई भी skin disease है, the patient is definitely going to use a steroid cream and try first. Okay? Because that is their previous experience. So always ask about the previous cream so that you will understand ये जो lesion जो आप देख रहे हो, is it a manipulated lesion, right? So maybe the lesion was not like this, like what you're seeing it today. So always ask whether it is whether previous creams were used. And the final thing is, steroid misuse leads to tinea incognito. Steroid misuse will lead to tinea incognito. Yeah. See, terbinafine resistance, yes, these days a lot of terbinafine resistance can be seen. Now, again, the only option is to go for different types of antifungal agents. So don't stick on to a single prescription. Okay? Because earlier during our discussion, I showed you multiple options, right? So don't have an option of just prescribing terbinafine in all the cases. आपको एक mix and match करना चाहिए, जैसे terbinafine in some patient, itraconazole, fluconazole, or even griseofulvin. Okay? So all these things can be used. Griseofulvin, especially when it comes to a tinea infection in children. Okay, जैसे I have written it here. Yeah, highly useful in pediatric and tinea capitis cases. Okay, so there griseofulvin can be even more better responsive. So all these could be the various treatment methodology that you can try. So this was our first session in pocket clinics, and these are the three clinical scenarios that I have today. And again, we have a few more sessions that is scheduled, and I hope that this will be of use for you, just helping you shape up into better clinicians. And if there is any queries, you can just let me know in the chat box. I'll be happy to answer you as well. And if not, we will definitely come up again with more sessions like this, and we'll have much more active discussions the coming days. Okay, thank you so much, all of you.